طيب بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على رسول الله. Welcome to our event today, COVID-19 in ambulatory care setting. Thank you very much for registering in this event. So we will start with an opening remark from Dr. Majid Fayyad, CEO and General Supervisor of King Faisal Special Hospital and Research Center General Organization. So, Your Excellency, you can go ahead and give your remark.
Thank you, Dr. Abdullah, and welcome you all. Good evening, everybody. I welcome you in this webinar that's organized by the Department of Family Medicine and Polyclinics, entitled the COVID-19 ambulatory care in an ambulatory care setting. This webinar is the first of many that King Faisal is intending to conduct amidst this crisis and this unusual time, where King Faisal continues to strive to be fulfill its objective to be a leader through education, research, and innovation for the society as a whole. This webinar is held with the help of Health Information Technology Affair team, and I thank them for their participation and for this for helping us conducting this. And I'm pleased to know that more than 2,000 healthcare workers from national and international institutions have signed up and registered to this event. At the end of the webinar, we will learn and expect to have more understanding about the role of ambulatory care in managing patients with COVID-19 in this epidemic, in this pandemic. Speakers will talk about different topics in the care of primary care and ambulatory care, laboratory testing for COVID-19 patients, patient triage, management of comorbidities, and medical education and training, and also mental health support during this pandemic. Because this is an unprecedented time, all industries, not only health industry, but all industries are scrambling and trying to conduct their business in an unusual way. And this is the time where we innovate. We at the healthcare sector are challenged. We are in the forefront in treatment and facing this pandemic. At the same time, we have to continue doing our business. Therefore, we have to be innovative. We have to look at the way we do things. We have to look at how we educate, and this webinar is one tool that we use in order to perform education in a different manner. In addition, also, we have to look at our protocol. We have to learn how to manage patients differently, utilize the resources to keep our patients safe and treat them as they need. So I'm looking forward personally to learn from this webinar, and I hope you'll find it useful. And at the conclusion, I'd like to thank all those who participated, namely the medical affairs, the academic and training affairs, the Department of Medicine, and in particular the section of infectious disease, the infection control and hospital epidemiology, and Department of Pathology and Laboratory Medicine, and many others who made this possible. I wish you all the best. And on top of that, the Department of Family Medicine and Polyclinic, led by Dr. Abdullah Khnizan, who worked very hard to getting this organized, conducted, and I'm sure you will find it informative. I wish you all the success, and I will have a wonderful evening, enlightening and educational. And thank you very much for tuning in. Thank you.
Thank you very much, Your Excellency. I must say that without the support of you personally and the leadership of King Faisal, conducting this seminar would not be possible. I would like to thank the team who also helped in organizing this event, led by Dr. Hussam Junaid and the group. So thank you very much for your help and support. And I will leave now the floor to the first session with Dr. Hussam Junaid as a moderator.
Thank you, Dr. Khanizan, and thank you, Your Excellency, Dr. Fayyad, for being with us today. Assalamu alaikum, everybody. So tonight we'll have, inshallah, our seminar, which will start now and will end at midnight. We have 8 speakers and covering different aspects of role of primary care and ambulatory care in the COVID-19 pandemic. We'll start with the first speaker, who will be our chairman, actually, Dr. Al-Khanizan. Each lecture will be like 20 minutes in average, and there will be like 5 minutes for your questions and answers. You can post your questions to us, and the moderators will take your questions and answer as much as we can, okay? So without any further delay, I would like to introduce Dr. Al-Khanizan. Abdullah Khanizan is our chairman in the Department of Family Medicine and Polyclinic, and he's our leader. And he's going to talk today about the role of primary care during COVID-19 pandemic.
Bismillah, thank you very much, Dr. Hussam Junaid. I will give this brief talk about the role of primary care during COVID-19 pandemic. So the main objective is to give a practical guide for ambulatory care setting and primary care setting during COVID-19 pandemic. And I will focus mainly on primary care. And when I say primary care, I refer to primary care, family medicine, polyclinic. Our department name is Department of Family Medicine and Polyclinic. So these kind of services, I think, represent the outpatient setting and the ambulatory care setting. Just when I say primary care, I refer to all of this group. Why we are focusing on primary care, ambulatory care setting during COVID-19 pandemic. I think currently this is actually the current focus, and it's clear right now that the fight against COVID-19 is shifting from in-hospital, in ICU care to primary care. This is especially true in our country because we know, based on our statistics, and I think this is the result of the tremendous and the huge effort that was done early on by the government and by the Ministry of Health. And as you know, yes, we have a surge currently in our country, Saudi Arabia. However, mortality rate is around 0.7%, one of the lowest in the world. And ICU admission and need is like 0.6%, again, one of the lowest in the world. And that's why it's clear that the fight against this virus will be shifted from in hospital to ambulatory care, and primary care should take the lead in fighting this virus. It's very important to provide and equip primary healthcare services with the right setting in order to fight against this disease. This includes access to testing for early detection, isolation, and tracing. In our setting, alhamdulillah, with the support of the leadership of our organization, King Faisal Special Hospital and Research Center, from day one, actually, we as family physician, we have the access to testing. I know that many sitting in the world, because I speak to some of my colleagues in Canada and other countries, they cannot actually, and they don't have access to testing for COVID-19. In our setting, we have it, and I think it's extremely important to have that privilege in order to help and contribute in the fight against this virus. It's also important to get an understanding of the community prevalence of this disease. If we want to do that, we have to give primary care physician across the country the privilege to do this test and make it easy, accessible, and easy to attain, the results of this test. In addition, it's clear that the world now is moving back to resume business as usual. Primary care should lead in this regard, especially with the fact that primary care is taking care of the prevention of diseases, management of chronic diseases, and urgent care. in order for primary care to really contribute significantly in the fight against this pandemic, we have to put in consideration risk management in primary care setting. And this is especially important in primary care because primary care is the first contact with patient, and those patients can be any patient, elderly, pregnant ladies, and someone who's at high risk for COVID-19, and someone who have the disease itself. So in addition to that, protection of healthcare workers is extremely important. They are our asset, in the fight against this virus. We know from the most advanced, or what we thought, the most advanced healthcare system in the world, mainly Western Europe and North American healthcare system, that 9 to 26% of all diagnosed COVID-19 cases were actually healthcare workers, based on the European CDC publication. This is really worrisome, and this is a lesson that we need to learn in our region and in our country. So we must, ensure the safety of our healthcare workers. Of course, protection of patients and their families who are coming to the primary healthcare centers and family medicine clinic is also extremely important. Airborne infection isolation rooms is a very important asset when it comes to the fight against this virus. These kind of isolation rooms are readily available in most of the hospitals and most of the emergency rooms. However, generally speaking, these kind of settings are really deficient in most of the primary healthcare center and family medicine clinic. In our setting, alhamdulillah, we have actually one built-in kind of isolation room, airborne infection isolation room. However, we realized from day one that this will not be enough. We did hundreds of testing, and we picked a few cases. And that's why we actually managed to convert 2 of our rooms, and this is probably what many ambulatory care settings need to do, to convert 1 or 2 rooms into airborne infection isolation room using the portable HEPA filter, which is an acceptable way of doing so. So in our setting, we had 2 additional rooms supported with portable HEPA filters. In addition to that, patients who are evaluated, they should be prioritized, and the risk assessment should be implemented. And those who are at high risk for the disease, they must be evaluated by a single nurse and a single physician in an isolated negative pressure room. This is extremely important for risk management and for the protection of healthcare workers. One nurse with the full PPE should assist the patient and does the swab if needed, and the same thing, one physician with full PPE should evaluate that patient. This will ensure patient safety, because if there is and this can happen, should not happen, but it can happen, a violation of the infection control precaution measures, at least one staff or a very limited number of staff will be affected. So they will be tested and isolated for 1 week or 2 weeks, depending on the risk assessment of that incidence. In addition, this will help in the cleaning efficiency with hydrogen peroxide and other disinfectant for these rooms where we manage a high-risk patient, to reduce the risk of contamination. And this will help also to conserve the PPE, because you don't want a new full PPE for each patient that you evaluate. In our setting, we designated one single nurse and one single physician equipped and dressed with the full PPE for the session. And as you know, in our setting, alhamdulillah, we have enough PPE, and we did not have any deficiency of PPE. However, this is a global issue, shortage of PPE. That's why we should not deplete our resources. In terms of the different services that is being provided by primary care and family medicine and ambulatory care during the COVID-19 pandemic, these services include and can be transformed and were transformed actually into virtual clinics. In our setting since 2015, we are using virtual clinics, so this made things easy for us. Telephone clinics is more practical, and especially if we have remote access to the electronic medical records. In our setting, we have that. That's why those who have clinic, we ask them not to come to the hospital. They can do their clinic while they're at home, just part of the risk management and lowering the risk on everybody. And also we give access, remote access to the electronic medical records for our residents who are really supporting us, and they're really providing excellent service and help for us. Face-to-face clinic is sometimes you have to do it. Patients who have significant lab results or radiological result and they need full assessment, you have to call them and see them face to face. Patient, especially children immunization, you cannot give vaccination virtually. So you have to meet the patient face to face. And the current recommendation is not to delay vaccination, until the crisis finish. And this is what we are doing actually. However, we are spacing our appointment, and we are supporting the Well Baby Clinic with more, nurses, because crowdedness and congestion is our enemy during this pandemic. Prenatal care is another important service that might need to be provided face to face, especially in pregnant ladies at high risk, or pregnant ladies at the later stages of their pregnancy. In our organization, still we are hiring staff to support the organization, and we have to do this face to face. Urgent care, somebody who's presenting with urgent issues, and to help relieving our emergency, we are opening actually an urgent care center to support the hospital, support the staff, and support our patient population. And urgent care, of course, must be done face to face. We actually have already a triaging telephone hotline to help our patient population. However, some of them, they have to come and they have to be seen face to face within our urgent care center. Early screening of the patient with the SARI criteria, which is a criteria that can predict and categorize the patient, whether the patient is high risk or low risk for severe acute respiratory illness, namely COVID-19. These criteria include presence of fever, history of cough, travel history, and things like that. So this should be done early on upon registration. We should not wait until the triaging of the patient. And if SARI in our setting is more than or equal to 4, the patient will be categorized as high risk, patient will be prioritized, and the patient will be moved immediately to the airborne infection isolation room. This is extremely important to lower the risk of infection for the healthcare workers and for other patients who are attending to the urgent care center. Then the patient will be triaged and assessed by a single nurse and a single physician equipped with full PPEs. If the patient needs to be swabbed, it will be swabbed in that room. Then the room will be disinfected after discharging the patient. Medication will be brought to the patient while in the room. Patient will be discharged home with a sick note for at least 2 days, and we will follow up the result. Thankfully, in our setting, we can get the result like within hours, maximum 24 hours. And if the result is positive, we will inform infection control to do full investigation and contact tracing if there is any issue in this regard. This is our isolation room. Again, this is the one we created with the HEPA filter. And this is one of our nurses actually in our urgent care center, fully equipped with the PPEs. Thank you very much, Yelva. This is the process of care that we are providing in our urgent care center. As I mentioned, patient will be evaluated once they enter into the unit. Actually, in the whole organization, surgical mask. Patient will be given surgical mask, temperature will be measured, and SARI score will be evaluated. If SARI score is 4 or more, if SARI score is less than 4, patient will be triaged like anybody else as usual. If the patient has a SARI score of 4 or more, we will move the patient directly to the isolation room where he will be evaluated by a single nurse, a single physician, equipped with full PPE. If swabbing is needed, will be done. Then the patient will be sent home and the isolation room will be disinfected with hydrogen peroxide and other disinfectant. It's extremely important to continue your communication during this pandemic with your catchment population. Through hotline. This is what we are doing. SMS messages, WhatsApp, and WhatsApp in our country, as you know, is a very popular application. That's why we decided to use it. These applications, especially the hotline, can help in triaging patient education, guidance, answering their questions and queries. I think primary healthcare services in our country and all over the world need to be very adaptive to the changes within the crisis. We try to do so in our unit. For example, in the beginning of the crisis, there was a huge number of travelers people coming from outside our country, from area where the endemic and the pandemic was hitting this area hard. And that's why, there are certain criteria that we are following, testing, home isolation, and whether the patient should go back to work or not, this kind of question. We're evaluating it in a clinic devoted for this. Also, in our organization, we decided to check on employee at risk for COVID-19, like patient or employee who are immunocompromised or active cancer treatment, or pregnant employees who are at high risk in their pregnancy or in a later stage in their pregnancy. So we're allowing them to work from home. Whenever we find a case, contact tracing, including risk assessment and testing for those contacts, is something huge that we were also contributing to with the help of the infection control. In addition to that, we have to be ready and we have to have plans for the escalation. Hopefully this will not happen, but we have to have our plans. As you know, in our country, we are in a surge mode. And that's why we have, to plan if things get worse. In our setting, we will actually contribute mainly to the emergency, covering the emergency. And actually, we started already doing some shift in the emergency room. If needed, we can also help in the inpatient care, and if things get worse, we can also help with the ICU. Actually, a group of our department, including some of the trainees, have completed theoretical course in ICU that the organization is providing, in addition to a practical session training in the field of ICU, just in case. Medication and supplies are extremely important during the COVID-19 pandemic. We have our patient population have access to the electronic refill services through the specific app. We call it Sahati. In addition to that, we have a medication refill hotline, because this is a big thing. That's why we devoted one line for this. We receive actually every day more than 100 requests for medication refill through these different services. In terms of the delivery of the medication, drive-through services were provided by the organization. But as you know, we had the curfew for some time here in Riyadh, and that's why home delivery was another option through mailing medication into the patient. Of course, those who come and attend in the urgent care clinic and center, on-site dispensing with certain precaution is still available. Just a few tips for primary care leaders during the COVID-19 pandemic. First of all, the process of care must be lean and must be prioritized. So those who are at high risk for COVID-19, they should be prioritized. They should not be waiting in the waiting areas, extremely important. And as I mentioned, from our experience, alhamdulillah, following a strict, application of these rules and regulation of risk management and infection control precautions, really helped us that in reality, even the first patient that we diagnosed with COVID-19, our colleague who diagnosed that case, he was working next day because based on the risk management which was conducted by infection control, he was not at risk for infection, fully protected. Communication with the team is extremely important. We have a relatively large unit. We have more than 35 consultant physicians working with us. We see 700, 800 patients daily, and we have about 30 residents working with us. In addition to the nursing team, we have a regular meeting, since the epidemic, at least 3 times a week. Communication with the patient is also extremely important. And that's why we opened the gate for the WhatsApp with the hotline, in addition to the face-to-face interaction with the patient in the urgent care center. Extremely important. Because you can prevent infection from COVID-19 or diagnose it, and the impact of it in our country at least was minimal. But you don't want to lose people because of patient having angina or chest pain or stroke or things like that. In addition, care within primary healthcare setting should be delivered in teams. And this is what we are doing. We have teams that cover the urgent care, different teams in a week. And the purpose of this is just in case there was a violation of the infection control precaution measures, and there was an outbreak or infection within the healthcare worker team because of a patient that we saw. At least that team can be, isolated, can be tested, can be, isolated at home for 7 days or 14 days, depending on the risk assessment. Still you have the rest of your team who can cover the service. Extremely important. This includes physicians, nurses, supportive staff, and we do this, and we are very strict with this. Leaders of the primary healthcare center, the chairman, the head section, the deputy chairman, the head nurse, deputy head nurse, they should not take shift, all together at once. So they should spread themselves into different shifts. Of course, all of these meetings we'll talk about will be virtual. Even within the management team should be done virtually to minimize the risk of infection within the healthcare in general, healthcare workers in general, and the management team especially. Of course, protection of healthcare worker should be paramount, and we should have zero tolerance to any deviation that can affect our healthcare workers, because they are the asset, the real asset in the fight against this virus. And from what we have seen in what we thought the best healthcare system in the world, these really give us clear lesson that take care of your healthcare workers. Finally, in conclusion, the battlefield against COVID-19 is shifting for sure to ambulatory care and primary care setting, and that's why we need to be ready. I think resources must be moved to the primary care setting. These resources include human resources and equipment, isolation rooms, extremely important, and access to testing. We are in a setting where, you know, we have full access to testing, but we know that many settings, they don't have this privilege. I think this should be, you know, a priority, especially in our country and elsewhere, if we want to fight this virus at the community level. And this is the target now for most of the healthcare system: testing, isolation, and tracing. This cannot be done without, you know, providing tests to the primary care setting. In addition, infection control, in general, precautions and systems are very well developed when it comes to in-hospital care. However, it's not as much developed as, you know, in the primary care setting in our country and you know, all over the world. And that's why I think we need to shift the focus to especially in the field of infection control towards, you know, better protection and better equipment in the primary healthcare setting for infection control measures and procedures, especially when it comes to airborne infection isolation rooms. Thank you very much.
Thank you, Dr. Khnezan, for your very comprehensive lecture. And I think this is one of the most important lectures today. So we got many questions regarding the CME. The CME will be 2 CME hours, and you can get the CME after filling the evaluation form, which will be sent again to you by email. If you entered as anonymous, actually, please write your name, but it's not very necessary because we'll look at the evaluation forms at the end, because there were so many questions regarding this. Now, we got like at least a couple of questions, but one of them I will direct to the other speakers because it's related to other topics that we will cover today. One of them is I will direct to Dr. Khnezan regarding the PPE. Also, we can direct it later, but maybe we can answer it now. The question was, can one PPE, one personal protective equipment used, meaning by the healthcare worker for more than one COVID patient, which means you move with the same PPE from one room to another room? This is the question.
No. After you know, evaluating one patient, the involved nurse and physician will change and will get another you know, set of equipment. But the point is, only one staff will do that. Not everybody is doing that with different patients. Just to you know, minimize that, be efficient in using the personal protective devices. And we have one full session on this issue.
Okay, thank you, Dr. Khnezan, again. If you can put yourself on mute. Now we'll move to the second speaker today so we can keep on time. Our second speaker today is Dr. Sahar Al-Khawadi, who is our section head of microbiology section in the laboratory department and pathology department. Dr. Sahar today will talk about the testing for the COVID-19 and the labs that we have available. So, yeah, your lecture now is on the screen. Go ahead, Doctor.
You want me to share? Assalamu alaikum wa rahmatullah. Thank you. Thank you, Dr. Junaid, and thank you, Dr. Abdullah Khnezan, for inviting me for this webinar. I will share my slides right now. And thank you for all the audience actually for inviting. Can you see my slides now?
Yes, we can see it.
Okay.
But it keeps.
Hello, can you see my slides now?
We saw it first and then it disappeared from my screen. You have to share it one time.
I don't know, it's not showing.
We can see it now. We can see it now.
You can see it now?
Yes.
Okay, just put it on full screen. Okay.
Yes.
Can you see it now?
Okay. Yes.
Okay.
Go ahead.
Sorry about this. And thank you, Dr. Junaid, and thank you, Dr. Abdullah Khnezan, for inviting me for this webinar. And thanks for all the audience and joining us at this time. I'll be talking about the laboratory diagnosis of COVID-19, and I will talk about the impact on microbiology laboratories in brief, and I will talk about the genomic structure of SARS-CoV-2, which is, I think, is very important to understand the testing, treatment, and vaccination for this virus, sample collection, and then I'm gonna discuss very briefly about the diagnostic platforms available in terms of RNA diagnosis, serology, and antigen detection, and then wrap up my presentation about the current diagnostic testing pitfalls. Now, we all know that in December 2019, the disease actually occurred in a cluster of patients of pneumonia in Wuhan in China. The organism soon was characterized in early January and was identified initially as COVID-19. Then the name was changed to SARS-CoV-2, which is severe acute respiratory syndrome related to coronavirus type 2. It's a new agent in the beta coronaviruses, and it was the etiological agent of COVID-19 disease. Now, when we look at the origin of the SARS-CoV-2, it's similar to the other corona, which is MERS corona, and they are all actually originated from bats. And the intermediate host, as you can see here, for the SARS, which happened in 2003, was the civet cats, and for the MERS was the camels as an intermediate host. And for the late agent, which is SARS-CoV-2, it has been speculation that there is more likely to be the pangolins, which are illegally sold in Chinese markets, are believed to be the intermediate host for this new virus, but still studies has to confirm this further. Now, when we look at the structure, as I mentioned, it's very important to know the genomic structure of SARS-CoV-2, because this forms the basic for all diagnostics, for all treatment, and the vaccination. So we all know it's an enveloped, single-stranded RNA virus, and this is very important to know because when we do the testing, we have to do reverse transcriptase to change the RNA to DNA in order for it to be detected. And we can see the characteristic crown that it's actually where the name comes from. It's the corona means Latin, more in Latin means crown, and you can see the reason for this crown is the spike protein, and you can see that and the glycoprotein on the envelope, and then there is the N protein, which is actually it's in the middle of the coronavirus. You can see it here incorporated with the RNA inside the nucleocapsid. And there is the membrane, the envelope protein, and the envelope protein. So this is the picture. And when we have a surface cut in the spike protein, here you can see the receptor binding domain. And this is where the virus actually, when it enters the cell, interacts with the angiotensin converting enzyme 2, which is the receptor of this virus in many tissues of the body. Now, this is the largest known virus, an RNA virus. So the length is 30 kilobase, and this is the other human coronaviruses. So it's the 7th human coronaviruses, in addition to the SARS, MERS corona, and the regular coronaviruses that cause normal respiratory infections. Now here we can look at the phylogenetic analysis. You can see it on the left side of the MADI. There are 4 groups of the coronaviruses: alpha, beta, gamma, and delta. The alpha and beta usually causes infections in humans and mammals. And you can see the SARS, the new COVID-19, and the SARS, MERS, they belong to the beta coronavirus. On the right side, you can see the genomic structure of the coronavirus. You can see here the non-structural protein. And then you can see here the structural protein, which I already alluded to, which is the spike, envelope, N, or nucleocapsid, and M. So these are very important, and I want you actually to concentrate on them because they will gonna used for testing. Now, when we look at the outbreak that happens over the years, and actually I've witnessed in 2003, we witnessed the SARS, and then the MERS in 2012, and lately the 2019, and you can see the number of cases for SARS-CoV-2 outweighs the number of cases for MERS and SARS. But luckily, alhamdulillah, that the mortality is lower than MERS or the SARS so far. Now, as I mentioned, I have witnessed the 3 outbreaks. This pandemic is totally different than the other pandemic that have happened. This pandemic, as Dr. Abdullah mentioned, have actually did a major impact on microbiology laboratories globally, because testing is the most important control measure to control or to curb the epidemiology, this pandemic. So early massive deployment of SARS diagnostics for case finding helped really to decrease or to curb the epidemic in several countries, as we saw in China and Korea and other countries. By testing, you can identify and isolate persons who are really contagious. Now, what's different of this virus than the other viruses in the group? This is a highly transmissible virus, rapid spread, especially among asymptomatic or minimally symptomatic carriers. Again, there is an absence of any cross-protective immunity from related viral infections. And the worry things that the undiagnosed cases are the infection source for almost 79% of documented cases. Now, the viral dynamics is still not very clearly defined, as we can see that the virus is excreted in many body fluids, and we don't know how long the shedding of this virus will last in these body fluids. Now we'll move to the type of samples. Now, the nasopharyngeal swabs is the most recommended samples to be collected, because the virus is usually found in the upper respiratory tract. Now, when the shortage, global shortage happened in the Copan or in the other transport media, the CDC have recommended actually to use the other type of swab, like the oropharyngeal, mid-turbinate, or anterior nasal samples. However, whenever you go deeper in sampling, like sputum, endotracheal aspirates, or BAL, they have actually greater sensitivity, because the amount of the virus is usually more in the lower respiratory tract. The flocked swab is the actually recommended swab. This is synthetic material for the to be collected. Poor collection, you have to know that it will result in false negative testing. So appropriate method should be followed in collection of these samples. Now, this is a study that have shown the detection of SARS in different types of clinical samples. This is done in China. Over 200 patients, almost 1,000 specimens were collected, and you can see here the BAL and fibrobronchoscopy brush biopsy were most sensitive. All the samples are almost were positive, followed by sputum, pharyngeal, and nasal swabs. Also, in the feces has actually been detected, and you can see the cycle threshold here were very low actually for the different type of samples. The lower respiratory and then the upper respiratory tract samples. This is the same actually slide showing the CT value. This is anything above 40 cycle threshold usually is considered negative. 40 and below usually considered positive. And you can see here that most type of samples, including the bronchoalveolar lavage, pharyngeal, sputum, they were all positive. So this virus can be detected in most type of sample, which may explain the rapid spread. In addition, another important find, like testing of specimen from multiple sites, may improve your sensitivity of detection and may reduce your false negative results. Now, from this, there are several things that you have to consider when you are requesting this test in your laboratories and your microbiology laboratory. I don't want to go over all of these things, but very important to know, because there are two types of tests that they detect the virus or indirectly detect the antibody. So you should know what your lab is, and most of the laboratories actually detect the virus itself. You should know the turnaround time so you can plan your procedures and your isolation throughput. And very important is, does your lab do a single testing or batching? And this is very important for the turnaround time. Now we're gonna move. I will move to the molecular diagnosis, and this is actually the most widely used method to diagnose COVID in most of the laboratories. Most of them at the laboratory, they use a real-time, which is a real-time reverse transcriptase PCR. Now, as I mentioned, because this is an RNA virus, we have to change it first to a cDNA in order for it to be detected, and we are using a real-time fluorescein. So after we extract the RNA, we usually amplify the DNA, the target of our detection by attaching it to fluorescein probes in different channels. And you can see here, we can monitor the CT value here. Anything less than 40, this is the CT value, and you can see here in the graph. Anything below 40 is considered positive. And if you have your graph actually early in the CT value, means that your viral load is high. Anything above 40 will be considered as negative. So by this, real time means that you can monitor your reaction while the amplification is happening. Most of the methods actually that they've been used, this is the first platform, which is the real reverse transcriptase PCR. Most of the methods, they have a high sensitivity and specificity, and they are using, actually, these are the molecular targets that have been used for the RT-PCR by using structural or different structural proteins. Some of the tests they will use like a screening using a general, like for example, E target, they may use as E and then confirm it by S or any other targets. Now, just to take you over the evolution that happened in molecular testing procedure, usually for all molecular procedure, this is the end point. You do 3 steps, you extract the RNA, then you amplify it, and then you detect the shaker, so 3 steps. Now, the real time that I spoke to, which is the first platform for diagnosis, you do extraction, and then you do amplification and detection in the same tube. Now, the more recent or rapid testing or sample to test, this is actually they call it point of care testing, have combined these 3 procedures in one, like you extract and then you amplify and detect immediately in one shot. And the more advanced, which is, I'm gonna take you now that they do these procedures as what they call it as a rapid molecular or point of care test or sample to answer. Now, these are very critical to spread the limit of infection. And we have actually several companies that they came up with these platforms. This is the second platform, molecular testing. All what you have to do, these are cartridge-based assays that you just put the sample here in this small cartridge and you keep it in the machine, and within 45 minutes, for example, for the CFID or a gene expert, 45 minutes you will get the results ready. Or you can use the QIAstat, which is actually will detect not only the COVID, but other viruses within 70 minutes. And there are actually the Abbott. I think everybody knew about this Abbott ID, which actually does this identification in 17 minutes in the United States. Now, the importance of these are very important to expand the point of care testing. Some of these equipment can be easily deployed outside in the community or in less or other than laboratories. So you can scale up your testing and enable clinical decisions, especially if you need to know the results immediately for isolation, for intubation, or for immediate emergency surgery. Now, these methods or these sample to answer or rapid molecular testing has been evaluated. This is a study that have evaluated 3 methods. They compared it to the reference standard method, which is like the 2 platform that I mentioned, real-time PCR, with these sample testing, and they found a very good sensitivity, starting with the CFID expert has actually 93% susceptibility, followed by the ePlex, and then lastly by the Abbott format. And the workflow is very easy. You take the sample and you test it immediately. What we have actually in our lab, we do have the CFID expert, and we have actually the QIAstat, which is not listed in here. Also, there are the recent study has compared the CFID expert with another Roche Cobas that the company actually claimed that they can do up to 3,000 samples per day. And they found a very good concordance between the CFID and the Roche Cobas. However, the Roche is like a single test. You can do the testing immediately once you receive it in the lab, and it takes only 45 minutes, random access, while the Cobas, you have to do batch testing. It's better to do batch testing rather than do a single test. And the combination, it's good actually to have 2 platforms in the lab, and this is what we have in our laboratory. We have a platform for batching, and we have a platform for a single agent testing to maximize the testing capabilities that you have in the lab. Now, very important before I wrap on the molecular testing, to know the duration of viral shedding. The RNA usually appears 1 to 2 days before the symptoms onset and persists for almost 7 to 12 days in moderate cases and 2 weeks in severe cases. It can be detected in multiple body fluids. The viral loads are usually highest after the symptom onset. Severe cases, they have usually high viral loads and prolonged shedding. Some of the mild cases that we mentioned that although the shedding of the virus lasted for a long time in body fluids, however, as you can see here for the nasopharynx and sputum, up to 37 days they were positive, but in the viral the culture was negative up to 7 days only. After 7 days, the viral culture was negative, which indicate that this most likely to be a dead virus. Now, what are the concerns about molecular testing in general? They do have a low probability in ruling out an infection. So the repeat testing with using molecular test is very important. The rapidity of these establishment, lack of an established reference method, use of differing sample collection and preparation method, incomplete understanding, as I mentioned, of the viral dynamics, especially at the later stages. There is a study in China actually have proven that 63% were negative at the end, like towards the later stages of infection. And a single test with upper respiratory and a positive single negative test and a positive test for other viruses should not be used as a reason to exclude COVID-19. So if you think of the disease, you have to repeat the testing on a different type of samples, and to document clearance, at least 2 negative respiratory samples, 2 negative tests should be acquired within 24 hours. However, I think this could be changed because of the prolonged shedding of the virus. Now, before I move, I'm going to move now to the antibody testing, and before I do that, just to remind you, the 2 major proteins that they are used in to detect the antibodies is the S protein, which is the spike protein, and the nucleocapsid protein, so S and N protein. And there are many studies actually have evolved about the antibodies. These are a very rapid test, can be done within 10-15 minutes. You take a drop of blood or a saliva, and you can read it as a pregnancy test by looking, you can just inoculate it here, and you can see it as a single line, or there's no line for IgG and IgM. Usually they appear after the 7 days, majority by 14 days. And however, these antibodies, they have a limited role in acute infections with the onset of symptoms and high viral load. They're usually good to do it after 1 week of the onset of symptoms. So the negative results should not be used to exclude the diagnosis, even with recent exposure. And sometimes there is a cross-reactivity to other viruses. Now, this is a diagram that can show you that the nucleic acid usually nucleic acid appears first, followed by the antigen that I'm going to talk about, and then the IgM usually appears within a week, and followed by IgG, and then the IgM drops within 2 weeks, while the IgG continues to increase in concentration. Now, this is a study that they looked at the early human response to SARS-CoV-2 in 280 plasma from 82 confirmed and 52 probable cases. All what I want to say here, like the median duration for IgM and IgA appeared actually within 5 days. Actually, both these antibodies appeared, followed by IgG within 14 days after the symptom onsets. The positive detection rate was significantly actually raised from 98% when you combine the PCR with the IgM ELISA. Compared when you do IgM, you utilize PCR with IgM, you can increase your detection rate with 98% compared to only 51% when you are using a single reverse transcriptase PCR. And the detection rate of the IgM is usually higher than the PCR after 1 week, where the level of RNA becomes lower. In this study, actually, they did a serial sampling in a large cohort study, and what they have mentioned that the antibodies, the percent of antibodies was less than 40% in the first 7 days. However, it increased to 194% and 79% for total antibodies, IgM and IgG respectively, after within 15 days. In contrast, the RNA usually decreased from 66% in the first 7 days to 45% during the 2 weeks. So it drops while the antibodies gets increasing. So combining both, as I mentioned, is important. And in addition, higher titer of antibodies was independently associated with a worse clinical classification. So quantitative total antibody titers were higher in critical cases. Now, neutralizing antibody, these are protective antibodies. In this study, they followed 175 recovered patients. The neutralizing antibody, they peaked usually at 10 to 15 days. However, 30% of the patient, they failed to develop these antibodies, and some patients actually did not develop them at all. And this has a very high implication for vaccines and use for convalescent serum. Now, how can we utilize this antibody testing? The diagnostic accuracy and the optimal use still remain undefined for the antibody testing. However, it can be used to assess prior infection and immunity for epidemiological purposes, ongoing surveillance, vaccine studies, risk assessment for healthcare workers. And I think it will have an impact on the late complication of disease when you have a false negative result due to decrease the RNA level and the viral shedding. You can at least see the level of antibodies in these patients. Now, still there are some questions to be answered. What's the duration and the level of antibody response that usually should be protective in severe versus mild cases? And will it be any role for serological testing in getting the patient back to the community or to be discharged? Now, the other test that is actually rapid, and there are many companies as well are coming up with it, is the antigen detection, not the antibody, is the antigen. More or less similar in principle. They use monoclonal antibodies against the nucleocapsid protein of the SARS-CoV-2, can be used as well as a point of care testing. However, in general, the antigen testing usually lacks sensitivity because they really depend on the quality of samples that you collect. So they really need a correct interpretation. As I mentioned, the antigen usually appears soon after the RNA and before the antibodies in the serum. Now, if we look at the 3 clinical conditions that you may be faced with these patients, either you face a patient in the incubation stage or in the symptomatic illness or the convalescence. Now, you will use all of these diagnostic testing that I have mentioned in all of these 3 cases. This is the easiest stage that you can use those testing, either for diagnosis or treatment initiation. But I think the difficulties is to diagnose patients, to monitor the contacts, screening for asymptomatic patients, or when you want to de-isolate or monitoring of the shedding. Now, this slide summarizes actually what I have mentioned about the real-time, the performance of all available testing as a real-time PCR, point of care testing, the antigen and serology, and you can see that during the asymptomatic or incubation period of the patient, in addition, screening the patient convalescent stage is the most, and most of these methods showed either actually the insufficient or low negative predictive value for these tests in these 2 scenarios. Now, what's the puzzling conditions that we have, and I think many of you will agree with me, like screening of asymptomatic person in the incubation phase is still a challenge because this may not have the antibodies, the RNA still, and the antibodies is not even yet developed. Accurate determination of the live viral shedding among these patients in the convalescence phase to form de-isolation decisions. And very important, I think, to provide the rapid testing and in a less well-equipped laboratories to curb the pandemic globally. And this is, I think, is a challenge for many laboratories. Now, I'm going to end up, this is my last slide, just to show you that the RNA is the first marker that appears, followed by the viral antigen. At the same time, when the viral RNA gets decreased, the IgM is actually starts to arise. And so this period here, I think the combination of RNA and antibody testing will be very helpful. So to conclude, the unprecedented outbreak of this COVID-19 globally has emphasized the importance of laboratory diagnosis to limit the spread and treat whoever have a serious disease. Nasopharyngeal nasopharyngeal swabs is the preferred sample, followed by sputum and BEL, which is more sensitive. Very important to use rapid sample to test assays. Utilizing of multiple assays covering different stages of infection may be a key to diagnose and control this pandemic. And thank you very much.
Thank you, Dr. Sahar, for this nice presentation. You covered everything that we need to know about the testing. I got some questions, actually. I think you covered most of the questions that are answered, but to wrap it up, I will just take a couple of questions. One of them is, I think you covered it again. Regarding the sensitivity and specificity, you mentioned this, but they are asking, can a screening test be a false negative? And what's the best sample from among all of those tests for screening?
Yes, you can get a false negative testing. The preferred sample is actually nasopharyngeal, depending on the patient. If you have like an intubated patient or patient producing sputum, I would rather prefer sputum production. But usually, and if the patient is not ready, because most of these screening will be happening in asymptomatic, nasopharyngeal swabs actually is acceptable for testing. Now, false negative can happen probably sometimes because of poor collection, or as I mentioned, if asymptomatic patient before the appearance of RNA or the appearance of the antibodies, you can get a false negative testing.
Thank you. Another quick question regarding your lecture. What do you think about mass screening for healthcare workers who work in a facility which have patients or take care of patients with COVID-19 patients? Do you think it's useful? Mass screening.
I think yes, and I think this is helpful. However, not with the current antibody testing that we have. We need to have at least, if you can have like a quantitative antibodies, not those rapid screening. Now, those rapid antibody screening can be used in the community or outside, like to screen, rapid screening. You may use these, but you have to know the drawbacks of these, because they may give you false negative assays. But for healthcare workers, I think, especially those healthcare workers that they are faced with working with COVID patients, I think it will be helpful to use them as a pilot study, to study their the level of antibodies in these patients, and to know their level of exposure for the virus.
Okay. Thank you again, Dr. Sahar. We'll move to the third lecture today. It's about management of COVID-19 patients with the outpatient perspective. The speaker will be our colleague, Dr. Reem Al-Maghribi, who is consultant in infectious disease department. So without any further delay, please, Dr. Reem, if you can upload your lecture.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Dr. Junaid and Dr. Al-Khanizan. And I would like also to thank the audience for being with us tonight. So in the next few minutes, I'm going to speak about the COVID-19 management in the outpatient setting. So as Dr. Sahar just mentioned, the SARS-CoV-2, which is the virus causing the COVID-19 infection, is one of the coronaviruses. And it's a novel coronavirus that was diagnosed in early 2020, but the cases go back to December 2019. It has homology with the other coronaviruses that either infect human or non-human species, and that will give, as Dr. Sahar mentioned, a lot of diagnostic tests and implications on the origin of this virus, and also other diagnostic tests that we heard about extensively. So in March 11, 2020, the WHO declared this virus and this disease to be a pandemic. And this has also, it did not only have an effect on the, it did not have an effect only on the magnitude of the disease, but also it raised the alertness of the international community, and also increased the preparedness of different countries, and also moved different resources among different countries, especially after the resolution or the decrease in the curve in China, and the movement and allocation of resources from China to other countries around the world. Okay. So it's very interesting that not only the number of cases had been increasing over the past 4 months, but also the number of publications. We have seen also an unprecedented number of publications that appears every single day and sometimes every single hour about different things in the clinical manifestation, risk factors, and management of this virus. So in the beginning of January, if we look back into the publications, it was mostly about the recognition of this virus and this disease by the international community. And then we started to know more about the Chinese observations in terms of their clinical experience, risk factor. And then we moved into their treatment experience in terms of antivirals and other medication that did not include antiviral medication. Which gave an indication to the global community that this is the time for randomized clinical trials to give us a better evidence about the treatment of this virus. that either included virus-specific targets or other than antivirals, that sometimes the immunomodulatory agents or agents that affect some parts of the immune response on the body. But also that carries a lot of problems with the gush that we see of the publication, because most of what we see currently is observational studies. Most of the time it's a preprint, it is not peer-reviewed, and that sometimes may lead into a rush approval for the medication. The FDA, since March 2020, issued an emergency use authorization for certain medications, which reminded the infectious disease community about the permission of use of peramivir back in 2019, which is a drug that was authorized also urgently for the treatment of the swine flu in 2009. But then after the pandemic has passed, we knew that this antiviral medication was not the greatest medication, so we knew more about it after the fact. Looking at this current pandemic, it's extremely important to find an effective treatment, especially in the absence of an effective vaccine. And the news about the presence of an effective vaccine has been also conflicting. Some people say it's going to be available within the next 1 year, and others will say that it may take up to 18 months for an effective vaccine to be available. But then you have also to add on top of that the production and then the global marketing of this vaccine. So we're looking into 2 years' time to get an effective vaccine up and running and globally distributed. So it's very important to find an effective treatment regimen, because we need to treat the active symptomatic cases, but we also need to treat the active asymptomatic cases. And that sometimes is needed to halt the transmission of the virus from one person to the other. But there is also a lot of discussion in the global community about the use of medication for pre- and post-exposure prophylaxis, especially when it comes to the healthcare workers or the infections in nursing homes. And that takes me to a very, very important point in the pathogenesis and the transmission of this virus, which is the pre-symptomatic infection. We now know for sure that the pre-symptomatic infection do exist in the cascade of infection with this virus. It contributed to a significant magnitude of the problem. So around 44% of the secondary transmission were infected during the index pre-symptomatic stage. Those patients who were traced and by contact tracing, and then they were diagnosed. Some studies, they looked into the CT values or the viral load of the viral shedding. And it is discovered that the viral shedding reached its peak 2 to 3 days before the onset of symptoms, but the infectiousness declined significantly 8 days after the symptoms. They may still continue to shed the virus, but not necessarily an active and infectious virus. But this just to point out to the importance of identifying asymptomatic patients and reasons of an effective treatment until a vaccine is available. This is also to show that the excretion or the presence of the virus is not only viable in the respiratory secretion, but it's also been present in other body fluid like blood and feces. Again, as this slide show, it also been excreted in pre-symptomatic stage, which again raised the concern if this is going to be an infectious source. Are we going to see other sources of infection other than the respiratory and droplet infections? I just wanted to point out that also the pre-symptomatic patients could release the virus in other body fluids. We still don't know that these other sources can be infectious or not, but it's just something that we have to keep an eye on. And I'm sure there are many publications will come in the near future about the dynamics of the virus and the other body fluids and whether this is a source of infection or not. This slide was shown by Dr. Sahar, so I'm not going to take a long time of it, but just to show that this virus can be excreted in multiple body fluids, which could be a source of infection. We still did not document that the virus is viable in any of these body fluid, but as I mentioned earlier, it's just something that we have to keep in mind. And why is the pre-symptomatic transmission is important in the outpatient setting? Because the pre-symptomatic transmission usually indicate that there is a community transmission. And whenever there is a community transmission, a patient, whether they are symptomatic or asymptomatic coming for the routine care, they will present to the outpatient clinic, then they'll put the healthcare worker and the other outpatient in the same clinic at risk for exposure, which means that at this stage we have to have universal infection prevention measures, which indicate that anybody now, we have to think of COVID-19. We have to ask even asymptomatic patient about a history of exposure, even if it's a remote exposure, especially that we know that we don't yet have the perfect test. So we have to be very vigilant about the history. We also need to make sure that we are using proper PPEs. And as we heard from Dr. Kharizan earlier, I think this is the time we have to utilize the virtual clinics to the max. The clinical presentation of COVID-19, the good news is that the majority of the patients, 81% of the patients, and this is based on the Chinese, European, and North American literature, do have mild illness, which is an individual who have any symptoms of upper respiratory tract that include cough, sore throat, malaise, but that should not include any shortness of breath, dyspnea, or abnormal imaging. Severe cases is seen in 14%. The percentage is much lower here in Saudi, and 5% critically ill patients. But what is it's important for physicians who handle the outpatient clinic or the family medicine clinic or primary care clinic, that even those patients with mild to moderate disease, if they have been one of the high risk population, they may progress within 1 week into a severe disease. And what we know so far about what we call high-risk population for progression into severe disease include patients who are older than 65, patients with chronic lung disease, cardiovascular diseases, diabetic, immunocompromised patient, and patient with end-stage organ disease. Over the past 2 days, we've heard some news from mainly from European countries about children going into severe diseases. The pathogenesis and the pathophysiology is not clearly understood, but it resembles disease of toxic shock syndrome. UK has reported this earlier this week. Today, there have been some reports from Italy indicating the same observation. So still, this is an evolving process, and we may see more high-risk group coming in the next future, in the near future. Other symptoms that we should also keep in consideration, GI manifestation with or without respiratory symptoms. It has been seen in around 40% in some series. That includes also some elevation in the liver function test. And I think this is also very important in the outpatient clinic to be aware that patients with elevated function test, even without respiratory symptoms, COVID-19 or SARS-CoV-2 infection should be also considered and ruled out. They could have also neurological manifestation. And more recently, we knew also that there is a good percentage of patients with taste and olfactory disorder, including anosmia. It's really interesting to hear from our colleagues here in the kingdom from different centers that this has been a common presentation for our patients. So hopefully, once we see the publication coming from the country, we will know exactly the magnitude and the percentage of this presentation in our population. It's very, I would say it's easy to identify severe disease. Those patients do not differ from other viral pneumonias, so they will have tachypnea, hypoxia, lung infiltrates. But then what happens after that is what's kind of unique about this virus is the evolution into cytokine storm, gush of immunological release of interleukins, and multiple cytokines that may lead into a cytokine release storm, which may require other medication other than the antiviral just to calm down the cytokine storm. This cartoon summarizes very nicely the list of medication that we have so far available for the treatment of SARS-CoV-2. And as you can see here, the treatment targets different stages of the viral replication within the cell. One of the most famous medications that we have been hearing about with a lot of political and medical implications that we had seen recently is the anti-malarial agent, chloroquine and hydroxychloroquine, which affect the membrane fusion and endocytosis, in addition to other mechanisms of action that I'm going to present in the next slide. We have also other targeted antiviral therapy like Arbidol, which is an antiviral that is only available in China and Russia, that has been studied in the Chinese literature, did not show really any great effect. And then it comes to the antiretroviral medication like lopinavir, ritonavir, which also inhibit the proteolysis stage. And then the polymerase inhibitor like ribavirin, remdesivir, and favipiravir. Favipiravir is another anti-influenza medication that is manufactured and approved in Japan for treatment of influenza. During this pandemic, it came to the surface and it's been undergoing multiple clinical trials. And we heard that there will be a soon clinical trial to start here in the kingdom about this medication. Remdesivir, another famous medication that we have been hearing about recently with some very conflicting results. Today, only a few hours ago, a study from China did not show any effect on severe disease. NIH study showed promising results. So I think even in randomized clinical trial, there is still no consensus on the best medication to use. But this is not the only targets that we are using or in the treatment of this disease. Also, other immunomodulatory agent, the most commonly used and the most commonly published about is tocilizumab, which is an IL-6 receptor inhibitor that has an effect on the cytokine storm assay. So the chloroquine and the hydroxychloroquine, as I mentioned earlier, it has an effect on the environment within the cell, which inhibits the the antigen expression and inhibits the immune activation. It also affects the signaling and the release of some immunomodulatory cytokines, which in turn result into decrease in the immune reaction of the body, but also has an active effect on the virus itself because of the presence of the acidic environment. Then the virus cannot replicate within the cell. This is the drug that has the most controversy around the world. So if we focus only on mild to moderate disease, which is the stages that probably can be treated as an outpatient, you will see the confusion and the disagreement about among the international literature. In Europe, for example, the Belgian guidelines recommend hydroxychloroquine for severe diseases, and in their guidelines they stated that to consider hydroxychloroquine for mild to moderate disease. Chinese guideline did recommend hydroxychloroquine and chloroquine for all hospitalized patients. Italian guideline did recommend it with or without lopinavir or ritonavir. NIH did not recommend any medication for mild to moderate disease. Their guideline came earlier this week, and they recommended only supportive care for mild to moderate disease or disease that can be treated as an outpatient, while other authority bodies like the WHO, the US CDC, and the Public Health England did not make any recommendation about chloroquine or hydroxychloroquine, so it is not even present in any of their treatment guidelines, which again tells you that this is a very difficult time for physicians to establish guidelines and to treat patients because of the conflicting results of the studies and also the recommendation from international literature. For post-exposure prophylaxis, which is again something that we as healthcare providers, either in the inpatient or the outpatient setting, we may think about, has been studied, and this study that I'm showing here in this slide, they used hydroxychloroquine as a post-exposure prophylaxis for an outbreak that happened in a nursing home. That happened from the index case, which is case E here, and it just shows you the movement of this patient among the healthcare facility. And then the second case that happened in case B. And the numbers here in the bottom just represent the times of the interventions that happened in this nursing care facility. So around day 3, when they recognized that this patient had been diagnosed with SARS-CoV-2, there could be a potential exposure of the healthcare worker and the other resident. The healthcare worker was completely under lockdown. All healthcare workers and the other residents in this nursing care facility were quarantined and tested, and all of them had received post-exposure prophylaxis with hydroxychloroquine. And you can see here the number was 221. By the end of the quarantine, by the end of day 12, all the people who were quarantined in this nursing care facility were negative, and until the publication of this paper, those people did not become positive either by symptoms or by testing. So it may indicate that this medication could be beneficial for post-exposure prophylaxis. When it comes to Kaletra or lopinavir-ritonavir, the initial study that showed that it did not work was released in New England Journal of Medicine in severe COVID-19 patients, but then the argument was maybe because this is a severe disease, maybe if we use it in the less severe disease, in the mild to moderate cases, we may see some benefits. But this is again proven not to be right. This is a recent study that was published earlier this month about the efficacy and the safety of this medication, or Arbidol, in mild to moderate COVID-19 cases. Was an exploratory randomized clinical trial. They randomized patients into 3 arms: lopinavir, ritonavir, Arbidol, or no antiviral therapy. And as you can see here, no difference in the viral shedding, also no difference in the symptoms relief among the 3 arms. So we just think that lopinavir, ritonavir is finally out from the game, and we don't think that it has any effect on halting the transmission or improving the disease in patients with COVID-19 infection. Other antivirals that has been studies, as I mentioned earlier, Arbidol, favipiravir, oseltamivir. Still, there is no data to support its efficacy in mild to moderate cases. And when I say efficacy, we really think of 2 main things. Does it decrease the time of symptoms? This is one. The second thing, does it prevent patients, especially the high-risk population, from going into severe disease? And we still did not have any results on these medications that I had mentioned so far to say that they work in any of the 2 points that I just mentioned. The Ministry of Health had already published their guidelines. This is the 4th version that was published earlier this month. And as you can see here, for mild to moderate diseases, the stronger recommendation is to treat those patients symptomatically, but then there was a softer recommendation in terms of whether to start those patients on hydroxychloroquine or not. So those are patients who are symptomatic, who are either admitted to hospitals, or if they have only mild symptoms, they could be in other facilities like hotels that the ministry has an agreement with, whether to give them an infection or whether to give them a medication or not. But in general, the recommendation from the Ministry of Health and the CDC, which we also follow the same recommendation, that all patients, all positive patients should be quarantined. Asymptomatic patients in hotels, mild symptoms like upper respiratory tract, who are people with no comorbidities, they could also be quarantined in hotels and isolated in hotels. But moderate to severe cases, as expected, they should be admitted to the hospital. We also were among the first, if not the first, institution in the kingdom to release treatment guidelines for the management of COVID-19. Our first guidelines was published March 5th, and we had our 4th revision on the 20th of this month. Considering the patient population that we see, most of our patients are immunocompromised, cardiology patients, patients on cancer, chemotherapy, or transplant patients. We prefer to treat all our symptomatic patients, even if they have mild symptoms, because we consider the majority of the patients who get treated at King Faisal to be a higher risk for progression to severe disease. So we divided the patients into different stages: asymptomatic, mild, moderate, and severe. As you can see here, stage A through D, and then we gave clear definition of each stage. And then we also identified the patients for high risk. As I mentioned, for stage A, those patients usually get treated in facilities like hotels, and they get discharged after having negative PCR. Stage B through D are all admitted, at least here in King Faisal. We did prefer to treat those patients with a combination of azithromycin and hydroxychloroquine based on the French studies that has been published over the past few weeks. We know that this has been controversial. We are now looking into our data. Hopefully we'll have more insight from looking into our data, and then we'll see whether there is a need to modify or change the guidelines accordingly. In pregnancy and lactation, the issue is even bigger and larger. There is no medication for treatment of COVID-19 in this patient population. As you would expect, most of the clinical trial actually excluded pregnant and lactating women. So it should be truly a multidisciplinary approach. It should be a shared decision-making between different parties, especially the gynecologists who are caring for those patients, and then the decision whether to treat or not to treat and which medication to choose should be taken in a consensus decision. Lastly, and I'm sure probably there will be a talk about this, but there has been a lot of talk about ACE inhibitor and IRBs and whether those can worsen the disease. And according to the American College of Cardiology, AHA, recent recommendation that was published in JAMA, they actually did not recommend stopping these medication because of the lack of evidence that it may worsen the disease. So in conclusions, pre-symptomatic transmission is a major source of disease transmission during this pandemic, and this is extremely important for outpatient setting because those patients may not show signs of infection. So taking history, taking precautions, especially wearing a mask, is of prime importance to protect the healthcare worker and also to protect the other patients who are in the clinic. Utilizing virtual and phone clinics are very, very important at this stage. Unfortunately, there is still no proven medication for treatment of COVID-19, especially for the treatment of mild to moderate diseases. The international guidelines did not agree on one approach, and I think there is no size fits all. I think each institution and each country is trying to do what is best for their resources and for the population that they have, and I think that is very understandable at this stage, with the lack of any evidence to support the use of one medication over the other. Here in King Faisal, we treat all symptomatic patients, considering the complexity of the cases that we see. And with that, I conclude. Thank you very much.
Thank you, Dr. Reem, for this presentation. If you can mute yourself kindly. Okay, so I think we have a couple of minutes for some questions. Some of the questions actually maybe will be deferred to another session, but here's one question regarding, I think you covered this and there is no clear answer for this, but what's the most potent drug for COVID-19? If you can say one answer. I mean, because as you mentioned, there are few data now, we cannot end contradictory.
Yeah, there is no potent drug. It depends really which source are you looking for. I think here in the kingdom, we saw some benefit of the hydroxychloroquine and azithromycin combination. We are looking forward into the publication. I know there are many publications that are in the latest stages of production, so hopefully that will be very helpful for us here in the kingdom. As I mentioned, today we have 2 papers on the same drug. Both are randomized controlled trial and showed different results, so it's really difficult now to say which is the potent drug. Okay,
there is one question regarding repeating the test when there is high suspicion for in a patient for COVID-19. So when should you repeat the test?
So it depends. So if the patient was during a trace contact,
yeah,
was it contact tracing or patient was symptomatic? So if the patient is symptomatic, if the test is negative, especially if the patient has been symptomatic for 2 to 3 days and the test is negative, the likelihood that they have the disease is smaller. It is not completely ruled out. And we have seen, especially recently, we have seen some reports on patients who were symptomatic for 6 days and then they have positive VALs. But in the asymptomatic stage, the best time to repeat the test is day 7 and then day 14. And that's supports the recommendation of the Ministry of Health, our recommendation, and also the international recommendation of isolating and quarantining those patients for a total of 14 days, because this is the time where we expect the test to turn back positive.
I will give you the last question because it was asked more than one time regarding the post-exposure prophylaxis. You mentioned a few words, but is it now really like established, you think, to use the post-exposure prophylaxis?
It is not, no, it is not recommended or it is not within the guidelines, but it's something that is really worth exploring. We know that there is a plan for a study to be led by the ministry on the post-exposure prophylaxis. I don't think the study has started yet, but we think that it may start in the next few days or weeks.